I took, what the heck is the last one? Clinical. So we had a whole lecture on the difference between 4 and 5.
Okay.
And we had to learn. So I know the 5. I don't know anything about the 4.
Okay.
So I have I think something for almost every single section on how each section is. Oh, probably more extensive.
Can you bring 2?
Sure, if I still have it, I don't mind. I'll make a copy.
If it's too much, if you look at this as simple,
Actually, get that up line.
that up on
That, I think I have website. Only 2. If it's not this, it's something very similar. No, it's not exactly this, but it's something very similar. Okay.
Yeah,
I'll look
you
for
guys
it.
done, I skipped these.
Sorry. I'm pretty sure I didn't know, so I should have it. Okay. Except I had about 70 pages. Like my notebook was like this, so I did get rid of some stuff.
Okay. See how that works. So we watched our video, talked a little bit more about differences in classifying somebody with the DSM-5. Functional assessment. So here's where we start to think about and consider the role that the substance plays in a person's life. So, do different things for different people. Some people, it's a social lubricant. Drink the party, guys, drink the party person. For others, it's a numbing agent. For others, it's something else. And so, the goal of the functional assessment is we're going to try and obtain a comprehensive understanding of of people's adjustment, how they adjusted across many different domains. And then to look at the research a little bit more about adjustment. I just didn't get a chance, I'm sorry. Adjustment, the way people adjust in their lives across many different domains. So, I have a question. How does this, and when I say this, I mean this whole here, differ from traditional psych rehab models, and when I'm thinking about it specifically the principles of psychiatric rehabilitation? This is a hard one. You gotta think back to your principles. Do you remember them? You don't remember the principles? Oh! I'm gonna have a heart attack. They should be tattooed on everyone's arms.
Yeah, I'm sure if I thought about it, it would start.
I will have to print up my whole guys and principles for every class. So
I wouldn't have said no if she was mean. Yeah, that's crazy.
I know.
I could have lied and like, yeah, I totally
if
got
you told me yes, I would have been like, great, which one is it?
That's
So
why
I was gonna find out.
I know.
Who is that? Oh, that's not
Okay. I just want to make sure it wasn't me in my new program.
It wants me to just.
Faye, you're thinking really hard. I'm just wondering
Yeah,
if
I'm
you
not
can
coming
remember.
up.
Okay.
Thank you.
So
Wait,
there,
I think I got one.
you got one.
I know it's part of it somehow, but I'm thinking quality of life is sticking in my brain.
That's
a goal, right?
Right.
I knew it was something there. I'm getting into
So
it.
there's 3 goals, and remember the 3 goals of psych rehab. That's one of them. Quality of life, recovery, community integration. Wellness is a value. There are 6 values. And there are 12 principles. So one of the principles is when you assess somebody in psych rehab model, you're assessing them in a specific domain. So let's say a person comes into your program and says, I want to get a job. You're going to assess them specifically on their ability to achieve that goal, get a job. They're not going to assess you on everything under the sun, even though some agencies that claim to be psych rehab still do that. It's hard to break people's habits. So when we assess in psych rehab, there's sort of a movement to really only look at the person's goal, the goal-related domain. So if you want to get a job for me, I don't really care about your substance use unless it's going to impact your ability to get a job. There are plenty of people who have substance abuse disorders that can work. So if I was a practitioner, I wasn't going to say, I'm sorry, you got to get that substance abuse problem in control before you can work. If you can do it, then you can do it. So these things might come out later, but in the initial stages, when you're meeting with somebody in the psych rehab, goals, values, and principles, it's a very environmental specific. It's the way it's worded, I think. As I said, I'll bring a copy of it next week. I love them. Yeah. So in this model, though, what are we doing? Comprehensive understanding across many different domains. They want to, in the straight or the substance abuse realm, if you're coming in presenting with a substance abuse disorder along with mental illness or signs and symptoms, they want to do a more global assessment. They're going to look at beyond just, I want to get sober. They're going to look at, what is your work life look like? What is your family life look like? What is your physical health look like? What is your, the typical areas that they ask about. So there are a few areas where we deviate, right? So psych rehab kind of has a different way of going about things when it's straight at mental illness. And in time cases where we have a dual diagnosis, the principles in the model changes slightly. So. All right, let's move on. Functional assessment. Functional analysis. So we really try to develop an understanding of the role. We really try to get an idea of what is the function, how does this substance function in this person's life? Now we try and convey the understanding of it to them, right? So we've been gathering information in the assessment phase. Now it's time to analyze that information. So now that we've learned info about the role of the substance, let's help develop an understanding of it. So here's where you're looking at patterns of usage. So the role might be, I use it as a social lubricant. We're talking about, alcohol here. And so the patterns of usage is, I use it when I go out to the bar. Oh, okay. How often do you go out to the bar? Once every couple months. Oh, okay. So the pattern of usage is you drink too much once every couple of months? Yes. Okay. Huh? Might be? Yeah. So that is altogether different, though, than the person that closes down the bar every night. Right? They're always there, staying there until the 8 wee hours in the morning. So the patterns of usage is very different in that case, despite there might be a similar reason or a similar role that it plays in the person's life. So you're going to have to identify and help them see these factors that are obstacles. So,
Quick question.
Yes.
In terms of binge drinking, doesn't that harm the internal?
Your body? Yeah, sure.
Far more worse than, I wouldn't say moderate, right? Moderate drinking or everyday.
I would say, well, I don't know. Depends on what you mean by harm your body. So is one, if you just drink for the first time and drink to excess and poison yourself, your body again.
That example you gave, the person said, I drink
once every couple of months.
But then they drink a whole bottle of.
They're not going to have the tolerance of somebody that drinks every day.
Right.
So somebody that gets wasted, completely obliterated once every couple of months, can probably do it off the same amount of booze every couple of months, right? They get their 6 drinks in them and they are good to go for the night, right? But if you're using every day, 6 drinks is eventually not going to do it. And that's one of the distinctive differences between somebody that has an addiction problem and somebody that's a binge drinker. So again, it comes down to what is the role of substance in a person's life and what is the pattern. Once every couple months, a lot easier to work with somebody with that kind of habit than somebody that's a daily drinker. There's a lot of functional issues that come along with that. So we had a few people, so I wanted to see these tests. So if anyone's interested in taking a look and seeing what the video looks like on the other side, Sean is 2 doors down that way. He's in the first classroom here. So does anyone want to take a quick look? Yeah, like 2 people at a time. So maybe you guys go. Go down to 501. Go in there, take a look, see if you can hear me, and then come back and just let me know if there's anything. Okay, so factors that are obstacles to recovery. Can anyone think of a way that this is going to might have an example here? So you got the person we've been talking about, right? Pattern of usage is binge drinker, goes out to the bar and completely loses all inhibitions. Doesn't do it all every day, but once every couple months. So
set up a little
what
screen.
might be an obstacle to
Okay. I mean, it doesn't really look much different than what they're saying there.
Okay. We can't actually see them.
So we can
Yeah,
have.
this person has a binge drinker once every few months, goes out to the bar, gets
No, it's only small.
picks up horrible hangover, back to their life.
Most part of
Can manage their life pretty well.
the sound is pretty good too.
But at home, we could use our.
You can use your headphones.
Okay, right.
And we
True.
also have this chat feature. You want to chat?
Might you be able to
Turn
identify?
on your microphone.
Okay, no, I'm sorry, I forgot exactly the question. So your answer is they have very little insight into the fact that this is an issue. But it might not be an issue, right? Maybe they don't have any negative consequences from this behavior. But let's say they do.
You might see the pattern. Like maybe their social drinking, I don't know, maybe when they're drinking, they start to bring out their problems, that's what makes them go over to the limit and binge. Does that make sense? You understand what I'm saying?
Do. So one of the factors that might be an obstacle is they don't know how to feel comfortable in social situations without using. So that's the factor, that's the obstacle. Person wants to have fun, right? Quality of life, we talk about goal, it's like rehab. So in order for them to have a high quality of life, you're gonna want people to feel comfortable in social situations. This person has an obstacle there. They need that as a initiator in order to be able to feel comfortable. So you're going to have to help them. You're going to have to teach that person how to get their needs met in ways that don't involve you. How are we going to help you feel more comfortable in this social situation that doesn't involve getting plastered? Any ideas? Yes.
Teaching them social skills, like having like a group.
Social skills training might be one way to do it. Have a group, role play different situations, discuss how it feels when you're embarrassed, talk to somebody, or what it might feel like if you get rejected. Minimize the fact it's like, it happened. What's going to happen? Did you die? Or this is going to develop some disease because the person didn't want to talk to you. That kind of helps see the realization, use some cognitive behavioral techniques, and yeah, you might be able to use those social skills in the future in in an environment that does not promote alcohol, and do a good job. Can you say something else?
Yeah, I was gonna say, for instance, if they're doing a group, they're gonna have like an assignment where they, try to socialize.
Absolutely. That would be
And
a
then-
critical feature of a cognitive behavioral group. It's like homework when the group's not meeting. You're like, oh, we talked about this social skills aspect this week. Go ahead out and try it this week. Walk up to somebody and start a conversation. That is really how the progress happens. That was a good question. So yeah, it might be skills training. It might be linking them to resources. It might be helping them learn new patterns and new, it might be like situations like, well, you may need to develop some new supports because these friends aren't going to change their behavior for you. So they're going to still go to the bar and blah, blah, blah. You want to make a change. It doesn't sound like they want to make a change. So how to get your needs met might be you need to develop some new healthier friendships rather than work on your skills. And then the skilled assessor is going to analyze all this information, determine that role, and be able to say, you know, these are some suggestions I have. Can you hear me?
Loud and clear.
All right.
See,
Anyone else want to go ahead next door and take a look? Yeah.
and the lights are off, so.
Lights are here or there?
No, here, so I'm saying, like, if anything you think you'd be,
Yeah.
it's fine.
No, yeah, I noticed in the video last week, at one point we had turned them off.
I know.
See the screen way better. So if everyone else is fine, you just with this one. So this is one of the ways, this is one of the points, like you can certainly invoke and notice and observe and point out people's strengths prior to this point in the relationship. But certainly this is the point where when you're talking to them about the factors that are obstacles to their recovery, you might also point out the things that they really got going for them good too. It's like, wow, you have this support in your life and that's really great. I don't come across a lot of people that have that kind of support. So you really to be commended for, you know, maintaining that. Or wow, it's awesome that you have this, you know, that you have this graduate degree, or that you have a job, or that you have a supportive family, or you find the strength in you know, wherever it might lie, even in the area, even in the people that seemingly have very little strengths, or the people that, I hate to say it, you just don't like. It's like, I look at you and I don't see one single strength. You're just a terrible person. It's like, you're very good at self-advocacy. It's like the nice way of saying, like, you are kind of like really annoying and aggressive about getting what you need. It's like, you're resourceful. You're resourceful. Yes, it's great. You get what you need. For sure. So it's a good time you point out strengths. And then the treatment plan comes, or in the mental health world, the support plan or the goal plan, or there's a lot of different names for this plan, treatment or otherwise, rehabilitation plan. They all mean the same thing. It's the place where you write down what the person wants, usually in this case of dual diagnosis, what's the goal? Often. Huh? Not always abstaining, but some kind of version of sobriety. Yeah, to decrease substance use, decrease substance use, or you know, to abstain, or to get 90 days clean, or you know, however they try to use it. It's in some way involving lowering their substance use. And then the plan, it identifies what the person needs right now. It's like you are there on the floor about to vomit on my carpet, you need a garbage can, right? Immediately. You need rehab or detox before we can even begin to work on counseling. You know, you need pharmacological treatment. You know, when I went into the doctor's office the day I surrendered, it's like, I give up. He's in the white flag. I can't do this anymore. I told my wife next day we went to my medical doctor. I didn't know what else to do. I just went in and was like, oh, I'm an alcoholic. And she's like, oh, that's a surprise. You should be in the hospital. And I'm like, I didn't think I had to go to the hospital. I'm just going to stop drinking. And they're like, well, how much are you drinking? And I told them, and they're like, well, if you stop, you might have a seizure. And so, yeah, you can't just quit cold turkey when you're alcoholic. You can quit heroin, though. Don't let any addicts tell you otherwise. They won't die. This, like, I have to wean myself off. They can stop. But alcoholics, somebody is a daily drinker dependent on alcohol, and they just stop, they can develop seizures. It's not good. So she was worried for me and wanted me detox in a hospital. I want to do that, but whatever, you're the doctor. But she couldn't get me to bed. It's going back to our first story, and I had insurance. So, she couldn't get me in bed that day, so my wife was with me, thank God. She's like, "You're gonna watch him, you know. If he has a seizure, you call it." Yeah. And she gave me meds. She gave me benzodiazepines, which alleviate the effects of work. It basically diminishes the possibility of having seizures, and sent me on my way. So the first one. But that was the immediate need in her mind, was that I needed inpatient treatment. And when it wasn't available, and she could sense that I wasn't really all that keen on it, she adjusted, and it was still the immediate need. It was like a physical withdrawal issue. And that was the immediate need, more so than anything long-term. What's his maintenance plan going to look like? Well, we're not even there yet. You can certainly begin with the end in mind, but certainly the immediate needs are going to take precedent over whatever long-term things become. You're certainly going to be incorporating motivational levels. So that day I was sort of like, I'm ready. It was when I entered preparation. Contemplation. So my motivational needs were different than the person that was getting dragged in there kicking and screaming by their angry spouse because, he hit me for the 17th time and I can't take it. Very different motivations. And that may be like, she's just aggressive. At that point, you'll develop strategies, figure out, all right, this might help you based on the results of the analysis, which had just happened. And then all of the team members have input. So if it's a team, multidisciplinary team that's working with the individual, they've all had different interactions, and they all have their own perspective, and all are valuable. So it's up to usually one person, some kind of qualified clinician, to take all of that, as well as what the person is telling you, and what the family is telling you, and what the reports are telling you, and put it all into one big document. Sounds easy, right? Well, let's think about how long all this takes. So the first step, to detect and classify, a week or two. And then we got to do the functional assessment. It's like, look at all those domains. Anyone ever do one of these? You will. We're only going to do part of it, though. You got to take it 2 to 3 weeks. We don't got that kind of time. And then the functional analysis, after you've assessed them, this is a lot of meeting with the person. A lot of this can be done after you've met with them. So it's like, we had our meeting, now I'm going to do my analysis, develop the treatment plan. Like, we'll have talked about the things, but we can now start to kind of put things into a document or get feedback of everybody presented to the person that's getting services for, their approval or revision suggestions. So 4 to 7 weeks? Derek's sitting there about to vomit in a garbage can. He doesn't have 4 to 7 weeks. So what do we do? Well, 4 to 6 weeks is preferred for the book. So let's shave a week off. Remember last week I talked about one of the drawbacks of rehab, taking so much damn time. So think about it. When I'm saying psych rehab, I'm normally thinking mental health, straight mental health, how time consuming it is. Now we're adding a substance abuse issue on top of that. It lengthens the time. It makes it more time consuming because there's more to talk about. There's more interactions or possible interactions between the illness and the addiction. So it's going to take longer. So it's like, So that's why these are not easy to do. This process is difficult and time-consuming, and especially when you have a lot of people. Now think about it. If it was just you and the person that's in recovery, you just have to factor in your opinion and their opinion, and maybe some people you talk to in the family. But if you have a whole clinical team, now it's like, now I got to talk to Amanda and get her opinion. Now I got to talk to Marta. What did you think when you saw that? And what did Jared think? And it's like all these people. Now it's like even lengthening the process. So it's necessary to get a thorough, accurate, comprehensive assessment, but it's a drawback that it takes so much time. Let's come back here for a reason. So what are some of the problems that come up with assessing people? Number one problem, by far, a failure to get the complete history. Why would people fail to get a complete history? I'll give you a hint, it's very, very straightforward. You don't effing ask.
Oh.
I didn't say say the word, I said F. But as you can see in my voice, it's annoying. They got you right in front of them. This is that casting a wide net thing. This is that assume they have a substance abuse issue until they tell you they don't and you verify with an independent source, whether it be a test or a family member. This is a problem, and it's a big problem logistically speaking because we have an overloaded system, right? We see epidemics of people with opiate addiction pouring into these let's say the outpatient clinics because we have plenty of spots there. These intake coordinators are being inundated. They don't have time. You see how long the process is. They miss things. They don't have, maybe they have some waiting room full of people that they have to see after you, and they do a rush job, and they don't ask all the questions that they're supposed to ask, and they miss you. I can relate because I've been in that situation, but it's, in a sense, it's like, you know, some of it is like, maybe they just straight up lie to you. It's like, well, your history is incomplete because the person didn't want to present with an accurate one. It's like, you can't blame them as much. But if you just don't take the time to ask, you can do better than that. Denial or minimalization. We should expect that from people, right? How much are you drinking these days? You know, you might want to add a few onto that if you're kind of, you know, in certain cases. If you think that the person might be minimizing their use, how often, how much. You want to try and verify with other people. Confusion about the effects of substance use. So you may not be able to tell how intoxicated somebody is because they have all impairments associated with their mental illness as well. So are they being forgetful because they're drank too much, or are they forgetful because they have a cognitive impairment associated with their schizophrenia? Hard to tell. Are they having trouble like focusing on me right now? Are their eyes dilated because of this medication that they're on side effect, or it's because of the street drug that they just bought? So it's hard sometimes to diagnose clearly if you have these mental health and substance interactions at play. People getting distracted by what's primary, what's secondary. Oh, we need to focus more on this because look, yeah, come on, get over that. Poor outcomes, research is clear. We don't do that. We don't say this one's primary, this one's secondary. Both of them are primary in our own world. We treat them as such. Cognitive, psychotic, mood distortions compromise the validity or truthfulness of the self-reported data. So Derek laying there on the floor might be horribly depressed. And me as the assessor is asking my doppelganger, Derek, you know, can you tell me how long you've been like this? And it's like, I've been like this for 20 years. It's like, he's so depressed, it just gets exaggerated. You know, how many tell me about the supports in your life. I don't have any effing supports. My life is terrible. When actually they do. But they're just, they're exaggerating it because their mood is so distorted because they're in such a depth of depression. Or they're floridly psychotic. And it's like, oh, so what do you do for a living? What do you mean, what do I do for a living? I'm the president of the United States. How do you not know that? I mean, you see me on TV? It's like, okay, there might be something off about this. They are, maybe it's drug induced. They took a substance and it triggered a psychotic episode. Or maybe it's their mental illness. Maybe it's just their baseline and this is what they normally believe. And it's just, everybody knows this about them and calls them president except you, the assessor. It could be a whole host of things. Or a cognitive thing. Like I said, it could just be due to the effects of their illness, schizophrenia being one of the big ones that has impact on cognitive distortions. They can't remember as well, or their what do they call that? Frame of reference is off. Like something they think only happened yesterday actually happened 2 weeks ago. It's hard for them to have depth perception. So these could be very real things that I've seen in my History of sanctions. So if a person thinks that you're going to be talking to the person's probation officer later, they might be giving you a different story than if they have complete confidence that you're in no way partnering with one person, right? Wouldn't that be any of us, right? We would maybe hold back a little of our story if we might think that it would get to people we do not want it to get to. Whereas if we have a completely open, trusting relationship and I'm working with Nina, who's my counselor, and I know Nina and I've been working with her and I know that she's in no way affiliated, I know that, I can trust the confidentiality in our relationship, I'm going to probably be more open to her than I would if I knew she was going to be typing up a report after I left about everything I told her that she could forward to the judge, my parole officer. I'm telling a different story to you, Nina. Sorry. Pre-motivational state. Oh, I just put this pretty clearly. It's hard to work with. I don't have a problem. You gotta convince them they have a problem. And if you've ever tried to do that to somebody, it's not easy. They're telling me I have a problem. I'll tell you something. So this is where we work with people. We can do things like motivational interviewing to help them see the discrepancy between what they're saying, I don't have a problem, and what is the truth. Oh, you say you don't have a problem, but you told me last week that you got fired from your job. Help me resolve this discrepancy. So we'll get into a lot more about motivational interviewing in the second half of this semester. The other book is the main focus of this. And then the different norms of substance abuse disorders. So it lends credence to the supersensitivity hypothesis we talked about in week 1. So less substance gives the person the same effect. So a person, if you're like a family member, you're seeing them, and they don't look like they're drinking that much. It's like, how could they be this drunk, It can't be the alcohol. It has to be something else. And it's like, no, it's because maybe they do have a higher sensitivity to substance than somebody that doesn't have it. So, any questions about these? They seem pretty logical, right? It's the things that it would be not expected, but you can understand why these things happen due to human error. We're not perfect. We're not robots. So we don't have perfect black and white type of the ability to differentiate, people telling you the truth or not, and a whole host of what's what I call secondary things, like all these other things that impact the real issue that's going on, the real substance problem, the real all these issues related to family or legal issues or health issues. Okay, detection. So, just going to stay back here while I lecture. We talked about casting a wide net, that you should maintain a high index of suspicion. So, what does that mean? Be naturally suspicious. Assume that people are, kind of holding back from you, and that you should go a little deeper. This was brought up by somebody earlier when we had, I asked a different question, this idea that it's a little easier to talk to people about their past use. So tell me about what things were like, when you were in college. And if it's somebody that's, older, and it's like, oh, I can tell you about what it was like in college. It's just less threatening if I talk about what I did 20 years ago. Then if you start right up with me, it's like, so, what did you use today? It's like, hey, I don't even know you. It's like, let's start a little further back in time. So it's it's a good best practice to kind of start in the past and work your way up to the present because it's a little less threatening, especially when you just know the person. Screen everyone, and when I mean screen, I mean tox screen. So like drug screen. Everyone at hospitals and ER visits. So if they end up in a hospital, if there's some sort of emergency that ends up where people need crisis treatment, it's often a good idea just for the sake of it since you're there to do the drug test, assuming that they're going to agree to it, of course, you might as well offer it. I know, having been with my wife, it's almost like, and I've gone on with my wife on a number of medical visits, anytime a woman of childbearing age goes to the doctor, it seems like they always get pregnancy tested. It's just like, well, since you're here, might as well make sure it's not a, pregnancy thing. It's the same kind of, since you're here, since you're, it's an emergent situation, why don't we just rule it out? Kind of the way you want to look at it. And again, some people are going to be like, nope, I'm not going to do that. It's like, okay, respect their right to refuse. And then, other ways you can detect, you can ask somebody using some kind of instrument. And we'll talk about a couple of those now. So we have the dolly. The tool that we mentioned earlier, which is specific. I can see somebody, just their head here. For mental health and substance use. So some of the things that are specific to the dolly, they look at, well, not specific, I'm saying, but some of the focal points. So it looks a lot at patterns. It looks at the ability to control one's use. So do you ever drink to the point where you lose control, or use to the point where you lose control? The big, red flag when you administer the dolly. Physical syndrome of dependence, talks about the consequences of use, subjective distress, use versus non-use, blah, blah, blah. Why don't we just look at the damn document? So this is the dolly. This is a copy of it. There's also a version of it in your appendix of your textbook, which I didn't actually get this copy from there, so it looks ever so slightly different. It's all the same questions, I believe. I think I checked it earlier today, but it's just slightly different, the page numbers don't line up exactly. The question numbers don't line up exactly. So you can see the instructions at the top. I'd like to ask you some questions about various aspects of your life, especially habits and choices that may affect your health. Please try to bear with me and answer each question. So I'm going to read the questions exactly as they are worded. In some cases, you'll answer yes or no. In other cases, you'll leave a number. It's very important for answers to be accurate and complete. Take your time. So everybody who administers this instrument says that same intro. The instructions are always the same to kind of get everybody to get the results as consistent as possible. Obviously, if they don't understand it, you would, explain to the point where they were able to understand. So look at the questions. Do you wear seatbelts while riding in the car? Kind of an interesting question. Maybe one you wouldn't expect on an instrument like this. Also very non-threatening, right? It's like, seatbelt usage, I can give that up to you. I don't know who you are. I'll tell you, yes, I wear my seatbelt. How many cigarettes do you smoke? Okay, so it's okay, cigarettes. Do you control your diet? So it's looking at how much control they have in their lives, what we said. Also control in a sense. Are you able to control the amount that you eat? How much you smoke? And now the question's into drinking. And then on page 2, more questions about drinking. Have you ever attended an AA meeting? Do you take a drink in the morning? Questions that would be the person says yes. Okay, this is a big clue that this person may have more than just, a casual usage habit. Have you used marijuana? Goes into, has cocaine been a problem? Then goes to, that's all the questions. So there are 18 questions, and then it is scored. And the actual scoring is in the appendix. I do not actually have a printing that says, this level indicates, it's a strong likelihood that the person has problems. But those are going to be, all of these assessments are kind of in a row back here. So this is the dolly, and then we'll talk about the assessment project. You'll be administering this to somebody. So it was developed by Rosenberg. As I said, it's 18 items. 3 are not scored. I guess they're more just yes, no type of questions. It takes about 6 minutes to complete. So that's a real positive. Very short, pretty short period of time to administer this survey. Again, you think about real world, waiting rooms filled with people. You can't be using an assessment. We're going to talk about one that's, 100 questions long. You got to get the information quickly. This is designed specifically for co-occurring disorders and looks at alcohol, cocaine, and cannabis only. That's the dolly. What was that? Okay. Some of the other assessments we have. So the Michigan alcohol screening test. So you can, each of these, I believe, are in your appendix. This one also has a web link where you could take it yourself and the computer will score it. It's 22 questions. I print this one. I didn't print that one, but that one is available in the back. The cage we discussed last week. We actually had a few of you look up what the 4 questions were. Also in the appendix of your book. Does anyone remember what they stand for? I remember 3 of them. Cut down. Try to cut down, that's C. Annoyed. Are you annoyed? Oh, they're right there. And annoyed. Guilty. And can anyone guess the last one? Eye-opener, yes. Duh. All right, so that one's very simple. It doesn't even take 6 minutes. This one is, this is a beast. Sorry for the yellow font. The ASI is the Addiction Severity Index. If you'd like to take a look at this behemoth, feel free to view that PDF. I'm not going to torture you. The ASI, I actually had to administer this to people in the integrated dual diagnosis treatment program that I worked in. And, talk about not realistic for the type of setting I was in. We had this very small contract with the county to receive some funding for specifically that population, the dual diagnosis. If we're talking very small, like $30,000 a year. Wasn't a whole lot of funding. And as a condition to get that funding, we had to do this 200 question ASI on every new person in our program that had a dual diagnosis. It almost became to the point where I talked to my director, I'm like, is it worth the $30,000? So you have to spend that many man hours administering this assessment. I mean, think about the people in recovery. It's like, you're going to ask me 200 questions now? You break it up. We made it as easy as we could. Yeah.
That's what I was gonna say. Many of them were inconclusive, right? Because I know they're not gonna sit down.
To be honest, I didn't even interpret the results. For me, it was all about just get it into the computer because
Even if they didn't finish the 200 questions.
we did what we could. If they sit there and said, I'm not going to answer your question, okay, refuse to answer. But you got to sit with them and do it. So a lot of it for us, it was just, rubber stamping. Let me just get it in because I have my own tools to assess the person that I trust. I'm just doing this for a funder, a regulator. So the ASI I'm not a fan of. Readiness assessment on the opposite end, very simple to use. Let me see if I can call this one up real quick. You may have seen this in another. Oh. Okay.
See, it's all that RAM running like 60 things at once here. So if this comes up, be a miracle.
It's 2 questions though. Sorry. Yes. So it asks the question of, you're sitting there in front of a person. Importance. How important is it that you quit using whatever it is you're using? On a scale of 1 to 10. And then how confident are you that you can? So you may have seen this scale used in what? They use it as part of the recovery planning process in Practicum 2. Yes. And it may have overlapped in other classes as well. So I knew it as the ICR scale. So I had a third question I would ask. How important is it that you cut down or stop? How confident are you on a scale of 1 to 10? And then the last question was, how ready are you to begin? So this is, again, on the opposite end of the spectrum of the ASI, just like a really easy way, along with the cage. The cage is specific only to alcohol, though. Way to get a quick assessment of the person's, how important it is for them. So that's going to get at motivation. How ready they feel and confident is getting at, what are the time frames we're looking at to change. Let me see what I had here. So that's the dolly. That's what I passed out to you guys. This is the MAST. The link that I included in the PowerPoint has the test here. So do you feel you are a normal drinker? Yes or no? Have you ever awakened and found you cannot remember a part of the evening? So similar questions to the dolly. And you can go through and then score it at the end, score my answers. There is a form, again, in the appendix. Here's the cage. And then here is the readiness ruler. So it's used in nicotine cessation, tobacco cessation. It's a big deal, so that's why tobacco just happens to be the one that they discuss here. Okay. All right, so classification. Let me just see. All right, I'm actually going to be stopping here. You have the, I think it's pretty close to the end. So one of the classification tools that we have is DSM-5 checklist for, now we talk about in the book, the drug use screening tool and the alcohol use screening tool. Those related to the DSM-4. So there's DSM-5 tool that I actually could not find in Moodle. So I sent an email to Professor Basto because I don't think I have it. So I'm working on getting that for you guys. Functional assessment is time intensive. Looks at a lot of domains. You're looking at insight, you're looking at the motivation of the person and the timeline follow back calendar. Okay. So this is also in your appendix, but I made a copy of it because I thought you may not want to write in directly in your book. So it is front and back. The first page, as you can see, for the assignment that we're going to talk about at the end of today, the assessment project, you're only going to be completing part 5 of this assessment tool. It's rather lengthy, so you can thank me later for not having to do the whole damn thing. So as you can see, there's big action. You only start way down here. Do you drink alcohol? And then it goes through all the questions. And then look at page 440. You see the drug and alcohol timeline follow back calendar. You know, the TLFGC. You know. So there are instructions on how to complete this on the very last page. How to kind of start, start with the current month, ask a series of questions. So today is blah, blah, blah. How many days in the 15 days of this month, did you use alcohol? Did you use this? Blah, blah, blah. So, yeah, it's comprehensive, yes.
I'm sorry, you want us to assess ourselves?
So we'll get to the project.
Oh, and we just use these directions only for section 5?
Yeah.
Well, those directions, I think, are just for that timeline on the second to last page. So it's how to administer this thing. The rest is just straightforward questions. It should be clear how to administer it. Okay, so these are the things that functional assessment looks at. As I said, you're only doing section 5, which is the substance use section. So you're going to be looking at pattern of use. The other 4 sections, which you can see are in your appendix, ask about background info, what the nature of your psych illness is. There's no kind of judgment on the clinician's part. So if the person denies that they have an illness, you roll with it, okay. Or sometimes you get a lot of like, oh, I don't have anxiety disorder, but I just got nerves. It's like, okay, cool. Tell me about your nerves. You know, they're very like meeting the person where they're at that stage. Ask about physical health, safety issues, things that compromise the person's quality of life, QOL, and their ability to participate in treatment. So this is where harm reduction strategies might come in. It's like if the person is at high risk to contract sexually transmitted diseases because they become promiscuous when they're, intoxicated. You might look at that as a safety issue, compromising potentially their quality of life, and take precautions, whether that be safe sex talk or other types of harm reduction things. You might look at the person's psychosocial adjustment. What does a functioning look like? Is the person, a full-time employee? Can they hold down that job? Do they have people that depend on them? Small children. Are they able to function in those roles? How motivated are they, and how much insight do they have, both into their issues that they're there for, as well as what they're good at. So then you'll again only be looking at section 5. Okay. Any questions? Perfect. All right, so we have a little exercise, a group activity. So you got to get in groups. This is group 1. Right. So we have 2 little vignettes, 2 little stories. Each of you have a different person. You'll read their little story, and then there are 4 questions for you to discuss amongst yourselves. Take about, say, 10 minutes, 12 minutes for you guys to talk amongst yourselves, and then we'll take 10 minutes to discuss as a group. So I got Darlene and Ibn. Who would you like to work on? Ibn? IBN? Or Darlene? You want Ibn? Ibn. There we go. You guys can take next. Here's something. Darlene is a lovely soul.
I am signing off, Sean.